Dr. Bijay is a PhD student at Central Hospital, Southeastern Railway Garden Beach.
My patient is an SK 47 years into female hospital resident of Garden. The chief complaints are difficulty in swallowing and nasal regurgitation for last 9 months, headache off and on for last 4 months, sudden loss of consciousness with continuous recovery, followed by inability to speak. 2 episodes in last 1 month. Coming to the history of presenting illness, patient was apparently asymptomatic 9 months back. Then she noticed difficulty in swallowing liquid along with nasal regurgitation. She had no problem with solid food and she had also intermittent intonation of voice. From last 4 months, she had recurrent headache precipitated by coughing and sudden flash of head. Severe throbbing in nature all over the cranium for 15 to 20 minutes and relieved by rest. On admission day, she had transient loss of consciousness with spontaneous recovery within 2 to 3 minutes, followed by inability to speak for more than half an hour. 2 such episodes occurred within last 1 month. She sometimes had tendency to fall while walking, but had never fallen. There is no history of trauma, rash, photophobia, photosensitivity, convulsions, vomiting, palpitation, bladder and bowel involvement, weight loss, aggressive behavior, geographical disorientation, sensory deficit, sensory disturbance. Past history, she had pulmonary coughs 20 years back, took ATT for 6 months. There is no history of hypertension, diabetes, asthma, surgery. History of shortening of right lower limb and gait disturbances from the age of 5 years. Now coming to personal history, non-smoker, non-alcoholic, vegetarian, pause where rabbit or normal. History of no history of sexual promiscuity. Married at the age of 16 years, blessed with 2 daughters and 1 son. Menstrual history, inactive at the age of 13 years. No history of OCD, regular. Family history, husband died 12 years back due to chronic alcoholism and liver disease. All other family members are in good health and no other history of similar illness. She took analgesics for headache, occasionally. Coming to general examination, conscious, alert, oriented, short stature, around 35 cm, weight 39 kg, BMI 50, no pallor, clubbing, cyanosis or edema, JBP not raised, no calculated info. Pulse 84 per minute regular, no rate of insulin. BP 130 82 mm right arm supine position, respiratory rate 18 per minute, temperature 98.6 degree Fahrenheit. Coming to central nervous system examination, the higher mental functions are within normal limit and speech difficulty, no speech difficulty at present. Cranial nerve first is normal, second there is visual acuity is decreased 6/24 in both eyes, and in third there is horizontal nystagmus. Fourth, sixth, fifth, seventh and eighth are normal. There is some technical error, I think so. There is nystagmus in the picture. 9th and 10th, there is left parietal vocal cord palsy present, gag reflex sluggish, sensation present over the posterior of the tongue. 11th and 12th are normal. Coming to the motor system, the power in the neck, trunk, shoulder, elbow, wrist, hand grips, hips, ankle are normal. Tone increase in the right upper limb and the lower limb. Nutrition is normal. Coordination, there is cerebral signs positive, that is finger nose test, knee heel test, Romberg test, Romberg sign positive, tendon walking positive, Risterococa initia present on the left side and there is no tremor. Sensory system, touch, pain, temperature normal, position, joint vibration is normal, tactile localization and discrimination is normal. Reflexes, right half of the body, that is biceps, superior, knee and ankle are brisk, and the left side is normal. And the plantar is extensor on the right side and the flexor on the left side. Coming to the locomotor system, gait, limping gait, posture scoliotic, upper limb both having equal sizes with normal bone, muscle and joint and soft tissue. Lower limb, right limb 5 cm shortened on the left side. There is restricted mobility in the right hip joint. In the spine, there is increased cervical lordosis and kyphoscoliosis present. No other obvious deformity present. Other systems, that is gastrointestinal, respiratory system and cardiovascular systems are normal. Coming to the clinical summary, a 47-year female with short stature, old ox, kyphoscoliosis, presented with loss of consciousness, headache, and left parietal vocal cord palsy. On examination, she had decreased visual acuity, horizontal nystagmus, parietal palsy present, Romberg positive discharge of co-kinase present, feature of upper motor neuron type of lesion in the right side.
So it's a beautiful case. So any comment from the postgraduates regarding the location of the lesion and the nature of the lesion? Anybody? Very interesting case.
Has he any history of fever, any infection, fever? No. But I think the caption there was some syncope as the patient.
Yes, sir.
And syncope.
Yes, sir. She fainted. After 2 to 3 minutes, she again gained the consciousness, but she can't speak for half an hour.
So I think it is short duration history.
Yes.
In the background of a chronic problem like old cox, some kyphoscoliosis, etc. And the patient had got, I think, loss of consciousness, fever, headache. So all this signifies a meningitis or some sort of meningitis.
No, there is no fever,
There is no history of fever.
No fever, no cough.
But I think patient had history of past tuberculosis.
Yes, sir. 20 years back, she was tuberculosis.
So naturally, I was thinking of some infective etiology in the form of tuberculosis in our country, reactivation tuberculosis. Then you can also think of if the patient is, I think the patient is short stature, I don't know what is the immune status of this patient. Naturally, fungal infections affecting the CNS, and many is also want to think of, who is a tubercular mimica, I say, something like cryptococcal meningitis. Of course, the patient should be immunosuppressed. Now, as the chairperson was telling that any neurological examination to find out what is the site of lesion. So naturally, the patient has got diffuse lesion, I think, not only the cerebral, not only the CNS, but also peripheral nerves have been involved, particularly cranial nerves. You talked about some cranial nerves, I think some, or lower motor neuron type. So both upper and lower motor neuron type with frontal extensor. So I think he has got either it could be a diffuse lesion or it could be a patchy lesion, particularly affecting the cerebellum, I think the brainstem and cerebellum, because patient for cerebral sides also. So naturally, site of lesion would be very difficult to pinpoint, except that it would be diffuse lesion, but more pointing on the brainstem, including cerebellum. Now I see that upper motor neuron on the right side. So naturally, Romberg is positive. So obviously, this signifies cerebellar involvement. So which side? I think most likely perhaps it will be right side. Tendency to fall. Patient have tendency to fall.
Yes, sir.
Which side? Right side or left side?
Sir, any side, but
Any side. So very difficult to pinpoint actually whether it's a truncal type of involvement or is it more of a peripheral cerebellar involvement. But I think it's more of a truncal type of involvement. Now, as the patient did not have any fever, so naturally one should think of whether we have got any differential other than infections. So naturally, other than infections should be obviously some malignancy, I think meningitis, etc., carcinomatous meningitis, or it could be some collagen vascular diseases. So I think these are my comments.
Very good comments, sir. Congrats, sir. I would request comments from the postgraduates. What is it? Can you comment on this? Particularly,
What you are
right
thinking?
side human lesion of this and these left side lesions. Can you remember any such syndromes or any particular location?
Congestion, kyphoscoliosis, headache, vocal palsy, palatal palsy, Romberg positive, and you have mentioned what in your mind?
Here we are finding involvement of the cerebellar tracts, and the spinocerebellar tract, along with the cranial nerve 9 and 10. Especially the kyphoscoliosis and a history of fall. She has a history of headache for a long time and a history of old cox. So we could probably think that they have been, since in the background of old cox, we can think of tuberculoma in the brainstem region involving the spinocerebellar tracts. We could also think of SOLs, intracranial SOLs involving the brainstem region affecting the spinocerebellar tract. However, since it's unilateral, we'll also like to keep an MSA type C in the lower down in the list.
Because you have given 2-3 etiology, very common.
Any comment from any other members?
Total duration?
See, Aya, working Aya.
No, total duration
She
of
is
It was from 9 months.
total 9 months. Before 9 months, she was absolutely normal.
Yes, sir.
Having different.
Only the history that 20 years back she was in the process.
Huh?
Only 20 years back she was in the process. The rest of the all things are within the 9 months.
So what is the things the UMN and cerebellum and this whole picture nystagmus? That is the point for the as you can say type of lesion.
For the location.
Yeah, type of lesion and site of lesion. Two type of our target is.
Okay, we can proceed.
So, Professor, do you think cervical cord compression, tubercular affection of the spinal cord, craniovertebral anomalies, posterior fossa as well, and multiple sclerosis? Now, investigation, hemoglobin 9.7%, total count normal, CLC normal, platelets are normal, blood sugar 97 mg%, blood urea 29, serum creatinine 1. All the LFT are normal and RFT are normal. Uric acid 3.4 mg% and serum calcium 9.4 mg per deciliter. ECG within normal unit, that is normal sinus rhythm. From X-ray skull, it is normal. X-ray cervical spine. X-ray cervical spine shows that there is
Any comment from the PTPs with this after this X-ray?
X-ray cervical spine shows cervical lordosis there is increase, complete fusion of C2, C3 vertebral bodies and the ossified lipids present. Coming to chest X-ray we have got normal with scoliosis. Coming to the hip joint, there is right hip joint has the avascular necrosis of the head of the femur. Coming to the MRI. MRI show marked construct located 22 mm below foramen magnum line, the cherry-1 malformation. Early ischemic change in the bilateral cerebral white matter. MRI of the cervical spine. This shows that there is tonsillar herniation compressing cervicomedullary regions of cord with incomplete fusion of C2, C3 vertebral bodies with early cervical spondylotic changes. So, the final diagnosis is cherry-1 malformation.
No doubt, it is beautiful case.
This is a very GRE 1 and you know GRE 1, 2, 3, 4, but 3, 4 doesn't exist in diet in early age. GRE 1 may manifest all the congenital condition, may manifest in the adult age. And this last year also we have shown 1 cases in this meeting here and they have been operated fully well, now is doing well. This year, this lady we have a plan for this decompression, but GRE1 exists in the society and it is more common now after the MRI pictures. Both the tonsil herniated into foramen magnum is known as GRE and this GRE is Australian pathologist who reported first time in 1897. So that report and along with Arnold, his teacher, Arnold GRE, there is a malformation, basically 2, 3 is Arnold GRE and GRE malformation 1 is independent existence. It is a congenital condition exists in the adult age. May present in the gradual onset of duration of the life. And this is the one condition with a very clear cut and back what. The report is now the definition of the herniation is 5 mm, more than 5 mm. Here it is the 22 mm. So very significant GRE1 is there. We have planned for to send in neurological center to get it operated for the compression. That whole picture now explain UMN type of foramen magnum compression and it was a overlapping clinical pictures with all the activities.
Would you want to put on any?
Yeah, very good question. That's why we have kept the caption. Yeah. Next slide. Or again, this one. Or again, this question is that why there is a syncope?
Sir, there is dysautonomia. Dysautonomia, so there is compression of this cervical tonsils are coming down. So there is CSF imbalance. The CSF imbalance will lead to sudden dysautonomia and then syncope.
Whole compression. I have gone in the searching for this last day before yesterday whole night. I have searched for this caption. Why there is a autonomy? This the whole last picture, this autonomic picture of the GRE. It is a late manifestation inside. and leading to dysautonomy, causing the fainting. So it is a one episode, not recurrent syncope. One episode of syncope, and it is very rare cause of the syncope in CRE.
And what is the relation with syringomyelia?
Yeah, most of the sir has rightly pointed. I have searched for that MRI picture for syringomyelia because most of the CRE formation in view duration from the syringomyelia. Here there is no syringomyelia till now, but in future if remain untreated may lead to the dilatation of canal. So we have searched for syringomyelia. Most of the CRE1 will present with the syringomyelia. Right.
Cherry 2 is in by manifest of the syringomyelia.
CRE2 may more.
Cherry 1 is only one.
Yeah.
So
And
it is a
CRE1
single with the breast and the protogenal body.
1 and 2, this 3 and 4 have a lifetime completely very poor. It should died within 4-5 years of the early life. 1 and 2, 1 is quite common, remaining in life, and 2 is less common, but with syringomyelia and other feature. 3, 4 do not live for the compatible for life.
So will you take into account this craniovertebral anomaly into this
Yes.
component also?
That's
The
why
one
there
with
is-
vertebral anomaly.
This is it is a congenital manifestation. It is a kyphoscoliosis, a spinal deformity, a spinal cord deformity from the early age, short stature 135. So all are leading to manifestation in this.
And plantar extensor on the right side, on one side.
Yeah.
How do you explain that?
Unilateral
Unilateral
In early phase there was a compression and gradually release
depending upon the nature of
nature of it. Gradually now she is alright. She is working in our
With due regards and thanks to our co-chairperson, Dr. Krishna, Dr. Jha, all the doctors in this hospital, all the postgraduates and all the delegates present over here, all the senior members, teachers. So we conclude. Thank you, Vijay.
we sincerely thank you.